Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor François Mach in Geneva, Switzerland, with whom we would like to discuss the 2025 focused update of the European Guidelines for the Management of Dyslipidemias, which have been published by the European Society of Cardiology, ESC, and the European Atherosclerosis Society, EAS, with Professor Mach as first author and ESC chairperson. Dear François, it's a pleasure and an honor for us to host you tonight.
As a short introduction, Professor Mach is an expert in the field of atherosclerosis, atherosclerotic disease development for many years. He has a long-standing track record in that, working first in the laboratory of Peter Libby in Boston, and then became full professor in the year 2000, and was appointed head of cardiology department in Geneva Hospital in 2002. He was president of the Swiss Society of Cardiology in 2012 till 14. He has an outstanding track record considering impact factor and age index. And I think he doesn't need any more introduction. He was already chairing the ESC Guidelines on Dyslipidemia in 2019, and now chaired the now present focused update. And Professor Mach, we are very, very honored to have you here today, and looking forward to your presentation. Thank you for coming.
Thank you for this introduction. Some words has been already mentioned, so I will probably go quickly in the first slides. I'm François Mach, head of the cardiology department here in Geneva, Switzerland, with a poor rainy evening today. It's like London poor time. I have absolutely no conflict of interest. It's exactly the slide that I present a couple of times now from this focus update. All honorarium that I may or have received or will receive from companies goes immediately to the department. Nothing in my pocket, in my family, absolutely nothing. And this is due to the endorsement to the ESC that I have since at least 15 years. It has been mentioned, I will summarize a work presented about dyslipidemia that have been published and presented in Madrid. We had the chance to have for a few hours the endorsement from the Spanish king, Felipe VI, but much more important, it has been mentioned that I'm not the first author, I co-chair. And I would like to acknowledge at least three important people. First, Koskinas from Benn, professor of cardiology in Benn, who co-chair together with Janine van Lennep from the Netherlands, from Rotterdam, the Netherlands. And we, the three, are the co-authors of these two papers, which are exactly the same papers published in the European Heart Journal, as mentioned, and the Atherosclerosis Journal. Why? Because this is endorsed by these two societies. I also would like to mention on the bottom right, a good friend, Tokgözoğlu from Ankara, Turkey, who was the task force coordinator. And we had a great time, the four of us, building or making this possible. And you have here, and you have some seconds to see all the family of the task force. It's really a family that bring this together. And thank you also from the United States. Mark Sabatin helped also a lot to make this possible. Importantly, because there have been some mistake, what is new in the 2025 focus is something that have been changed from 19. If you have no change in your area of expertise, it means that the recommendation from 2019 are still valid, remain completely valid. And we have had some companies, why you haven't cited our new molecule? I mean, there was nothing new from 2019 in your molecule. We are sorry. But the recommendation of 2019 still remain. So this implicate only new recommendation or recommendation that could have been upgrade. You will see one or downgrade. You will also see one at the end. Quickly now, we recommend with quite high class to use score 2 which has the benefit to be able to include persons or patients up to 89 years old. Before it was only 75, so clearly an advantage. And most importantly, it will give you a better prognostic of cardiomorbid mortality, which means not only death in the next 10 years of cardiovascular disease, but also morbidity, the fact that you may suffer from a stroke or being hospitalized for whatever things. And using SCORE2-OP, which is for all person, again, up to 89 years old. So this is completely new compared to the previous on the left, the previous score up to 70, 10 years fatal. Now we go to 89 and it's fatal and non-fatal, easy to use. And these new scores should be used to better classify the patients in the different low, moderate, high, very high, or even you will see a new category. It is based on something I will not put too much time there: age, sex, non-HDL cholesterol, systolic blood pressure, smoking, and geographic issue. So we have put here in red what have been changed to classify the patients in very high, moderate, low risk. You can see what has been changed from 2019 to 2025. Basically, most importantly, the use of SCORE2 or SCORE2-OP, which give you a percentage. If it's above 20%, everybody will be at very high risk. And chronic coronary syndrome, significant plaque, we don't say 50% or more, and markedly elevated calcium, coronary calcium score by CT. For high risk, what's changed basically is the percentage using SCORE2 or SCORE2-OP, above or equal 10%, below 20, and you make exactly the same for moderate risk or low risk. These have been calculated after long effort to reclassify better or properly the risk of these persons or these patients using SCORE2 or SCORE2-OP. I just mentioned that we have highlight and there is a new or change in the recommendation. It is not maybe, but should be, and this is regarding the presence of subclinical coronary by imaging or increasing calcium score using CT. And as you can see here, something which is new now, not only calcium score, but use risk modifier. And the risk modifier table is on this one. I will skip the fact that you know that there have been multiple studies using calcium score to predict different cardiovascular morbid mortality in different ethnics and thousands of persons or patients in many, many years. This is the risk modifier that we propose to use. There is some new things about stress symptoms here. Social deprivation, obesity was there, inactivation, chronic immune inflammatory disease. We had the question sometimes, oh, my patient has a cancer, which probably has a positive prognostic, but can I use SCORE? Yes. SCORE2-OP should not be used for diabetic patients because there is a SCORE2 for diabetic patients, and not in so-called secondary prevention. Patients who had already an event, they will be classified immediately and they should have their level of notably lipids already defined. This is for patients in primary, but they could be very high risk and they could have other disease such as chronic immune, or Crohn's disease, or cancer. Sleep apnea was already there and known as biomarker, and we'll talk a little bit about Lp(a). There are some new recommendation because some new evidence about Lp(a) and also persistent elevated CRP. Now about ethnicity, this was already present in the 2019, and I just put this from the 2021 prevention guidelines. Don't forget that the score should probably be adapted by multiplication of something that could increase or decrease depending on the ethnicity of the patients that you have in front of you. Asian population, and mostly Indians and Pakistan, should have a multiplication by 1.3 or 1.7 even sometimes. This is the figure that has been adapted from 2019. What has not been changed, and I think this is important for patients and for all our colleagues, is the levels of LDL that are recommended, the targets for low risk. It's 3 millimole, 115 milligram, moderate 2.6, 100, high risk 1.8, 70, or very high risk 1.4, 55. So this has not been changed. We did not have any scientific evidence to change these target values for LDL. What changed again is the parameters to qualify a patient in these different categories, mostly using the new SCORE2 and SCORE2 OP with the defined about percentage. You will classify to be in these kinds of high or very high risk or moderate risk, depending on the percentage calculated with SCORE2 or SCORE2 OP. And something new, we have put here as a class 2B. So it might be, again there, an extreme risk category, and we placed as might be reducing LDL cholesterol in patients qualifying for extreme risk. They should be, or they might be, sorry, below 1 millimole, which is 40 milligram per deciliter. What is not mentioning here in the classification for extreme risk, but in what I do, or I teach and I advise or ask my colleagues here in Geneva to do, is let's say a patient has an MI, so he or she will need to be below 55. But if Lp(a), we'll come back on Lp(a) is high, then he or she will be classified for me at even a higher risk than which is extreme risk. And I will try to decrease, hopefully reimbursed, his LDL to 1 millimole until we have the drugs. And we'll come back this in a minute. Until we have the drugs, hopefully, to reduce cardiovascular events by reducing Lp(a), lipoprotein small a. Now, we do have new recommendation for new therapeutics, and this is something with very high class and level of evidence, non-statin therapy with proven cardiovascular benefit. This is important. We have to stick to these rules at the ESC. With proven cardiovascular, taken alone or in combination, in patients who are unable. In the US guideline, they place unwilling. We did not place statin intolerance, but unable to. We can have a discussion about this. And the choice of this non-statin therapy with proven CAT should be based on the magnitude of additional LDL lowering. And depending, of course, but we cannot place this in the recommendation on the costs and the what could be offered in different places in the world. There is a new kit there called bempedoic acid, which we recommend class 1 level B. There is some trials, but at least one good outcome trial, positive, is now recommending patients who are unable to take statin therapy. And you can also, should be a combined bempedoic acid to maximally statin with or without ezetimibe for patients at high or very high risk in order to place them in a high chance to achieve the LDL goal. There is also another new kit, ivanacumab, which is quite rarely prescribed because we do have, at least in our regions in Europe, rare homozygous familial hypercholesterolemia, 5 years or older, who despite all the treatment that they tolerate, and they are not at goal of the figure that you have seen, then there is a fair chance that with this new monoclonal called evinacumab, these patients may reach their goal. Now, this is also a figure that is important. This will help a lot of, we do have this in our clinical units now. It's the mean average. Nothing is due for moderate high-intensity statin, ezetimibe, bempedoic acid alone, but I think it's important that we ask now to use more combination for reason A, it is very efficacious. adherence will be good, and it's cheap. I mean, ezetimibe, bempedoic acid, you can combine statin, ezetimibe, bempedoic acid, and we even go for the combination between high-intensity statin, ezetimibe, bempedoic acid, PCSK9. These are all drugs, at least alone, that have been proven cardiovascular benefit. And the arrow on the far right goes down to 80, 86%. So lots of our patients with low, moderate, high, or very high risk, they will reach to their target levels using combination therapy. It's not always cheap. We know that, but we have to stick to the numbers and the scientific data that we had so far. Some different categories of patients, of populations. A patient at the time of acute coronary syndromes, you will see 2 slides why we now recommend to intensify lipid-lowering therapy at the time of the index, which means during hospitalization. We do this here. We do have some patients coming on any lipid-lowering therapy, usually statins. Then the patient will add ezetimibe and hopefully increase a little bit the statin if this was not the case. And we also initiate combination therapy with high intensity plus ezetimibe during the index for the patient who were naive. I think the fact that in the past we did recommend to have a stepwise approach, you wait a couple of weeks. This is not any time affordable, and we know from the Sweetheart registry, which is a fantastic surveillance of patients in a real clinical world. This is not a randomized control study, but it clearly shows in thousands of patients after an MI that the sooner you have to reduce LDL, and we know how. It's combination therapy. You use pills combination or you use PCS depending on your health economics, but please, we have to lower very soon, as low as possible. This has been proven in a clearly normal, it's a beautiful study. Again, it's not randomized, but the patient who had the lowest risk after an MI are the patient who received immediate combination therapy using ezetimibe and statin at the time, because ezetimibe was starting in 2015, 20, and thus they were able to show that for the patient who, it's not randomized, again, but it's clinical daily practice. And they will do the same probably in 1-2 years using PCSK9, because PCSK9 were introduced in Sweden a bit later, as in Europe, in other countries, than ezetimibe. So we may even see a lower rate by using PCSK9 to reduce very soon, very low LDL to help these patients who are very high risk. What about lipoprotein small a? I'll go quickly. There might be some questions about what is APO small a. What we have to define is that depending on the numbers for being over the limit, if you place 50 milligram per deciliter, we'll come back, then it's 20% of Europeans. You have to do it once. It costs between 8 and 12 euro. Why once? Because it's mostly 90% only genetics. If you have a normal Lp(a), please never do it again. But in some countries, it could be, or in some continent, it could be up to 30%. 30%, that would be a huge numbers. It is close to 1.4 billion of person. They don't know if they haven't measured it. And we know now there is a clear positive correlation between the level of Lp(a) that circulate, it's mostly genetic, again, that circulate in our vessels, and the increased rate. It's a risk of having acute MI, aortic valve stenosis, even though we don't know exactly how it works, but also heart failure and morbid mortality for strokes. And one of the reasons, this was not in the guidelines, but one of the reasons is that per molecule, if I have to choose between one molecule or the other, clearly LDL is less risky, is less prone to atherosclerosis than Lp(a) per molecule. there is much, much more prevalence of patients with dyslipidemia and high LDL. This is why we have to treat them, and we do have drugs and combination, and there was an improvement. But Lp(a) per se, per molecule, will be at much more high risk of being pro-atherosclerotic because of pro-inflammatory, but also pro-thrombotic. So if you think about the fact that this molecule of LDL could generate atherosclerosis as LDL, but they also have the capacity, once the plaque is unstable, to make a clot, then you have the perfect killer. So that's why at least it's a good reason to measure it. That's a figure that was a lot of debate. First, in blue, you have the distribution of the normal population, in the normal population, of the level of Lp(a). So most of us will have a normal value, and some of them, depending on the ethnicity, again, the Black have more Lp(a), we know that. And we have a positive correlation starting at 50 nanomole, or let's say even 50 milligram deciliter, clear positive. And the higher in the blood, the higher the risk here as a hazard ratio of having a cardiovascular events. So that's the new recommendation for Lp(a) that I will read for you. Lp(a) level above 50 milligram deciliter. So it's 50 milligram deciliter. So it's here. Or 105 nanomole per liter should now be considered, should be considered 2A in all adults as a cardiovascular risk enhancer factor with higher Lp(a) level associated with great increase in risk. Now, I place this, is that it's a double, but the recommendation on Lp(a) from 2019 still remain. Should be considered at least once in an adult life person time to identify those with inherited level above 180 million, who may have a lifetime risk equivalent to heterozygous familial hypercholesterolemia, and thus it should be considered in a lifetime risk. Now, about Lp(a), we don't have drugs today to reduce Lp(a) sufficiently. You may remember niacin. In Europe, it's forbidden to prescribe niacin. It was close to 35%. Nobody knows why PCSK9 monoclonal and inclisiran decrease Lp(a). Thanks for them, but nobody. Statin does nothing. Honestly, it's sometimes plus 5%, less than 5%. We don't have drugs so far. But tomorrow, and I'll say tomorrow because the pelacarsen, I will say the company name, the names, Novartis, the study called Horizon, we have 50 patients here in Geneva in pelacarsen Horizon. They will give result at Munich 2026 ESC meeting. It reduced with an oligos, antisense, by 80%. That's a lot. But a bit later, probably 1 or 2 years later, will come Olpasiran from Amgen, Zelaziran, Lopadiziran from Lilly, silence therapy. This is 98%, almost no more Lp(a). It has been proven that all these drugs, either small interfering RNA or antisense, are very safe. Hopefully, they will not be too expensive. They are very efficacious, as seen in this slide. They are very safe. And hopefully, we don't know yet, there will be positive outcomes. There is a compound that will be small molecule that will be a pill. You're going to say, why coming back to pills? The only reason for the pill is the cost. And hopefully, this is less reduction, but this will push these guys, I'm sorry, these companies to reduce their price. There will be soon an oral anti-PCSK9. And I have friends, why? We are now in the area, François, of injectables. Once a month, twice a year, fantastic. And that costs a lot, much too much. Even silencing RNA costs, and they can reduce their price. The fact that there will be an oral PCSK9, I'm just changing fields there, but an oral PCSK9 will be a pill a day, but it will cost probably €2 a day. which will be 20 times less than monoclonals. Nevertheless, what you can do, this was not in the European, in the guidelines, is using the risk category, a lifetime risk that have been developed by this website. It's mainly Brian Ference. You just, this is a man of 50 years old with blah, blah, blood pressure, smoking, non-smoking. You calculate LDL, and that's the risk. 16.9 with LDL alone. You don't know LP-little. You measure LP-little, 10 bucks. The risk goes up to 35%. And there is, now you reclassify these patients. And what we can do to these patients with a high LP-little of this person is to be sure that all their risk factors are normalized. Smoking should be completely, okay, bended. Blood pressure should be completely normalized. Diabetes should be completely normal. And LDL could be, these are calculations, could be even, there is absolutely no risk. Blood pressure, you cannot go too low than too low. You will say, you will faint. Sugar, you will faint. But LDL, there is no risk to reduce even lower than the recommended because you have high LDL until the time it will come. By 12 to 48 months or 24 months, we will have fantastic drug that will put these patients at low risk. Now about triglyceride, these are slides from my friend Borge Norzegaard from Copenhagen. We do have, there are some data that will help us that clearly if you have an increased level of triglyceride in the blood, you have an increased risk of acute pancreatitis. But look at this. This is a follow-up of many years of 115,000 Danish. There would be clearly a positive link between the higher the LDL, the triglyceride, and the higher 400. For the same group of category, it's 4,000 MI. So clearly the risk of MI is 10 times more than the risk of acute pancreatitis, which is a very bad disease as well. There is no doubt that triglyceride is linked to atherosclerosis, to all-cause mortality, mainly due to cardiovascular mortality. Diet will do probably 10%. Of course, we don't like high percentage of alcohol. If you do physical activity, you can reduce, but that's marginal. As well as some of the drugs that we are used to use daily, statin will do 20%. In green, they have been proven in this population to reduce cardiovascular risk, even ezetimibe alone. The fibrate reduced, but they have not been proven for whatever reason. We can discuss about some side effects, some increasing of LDL, but they reduced, but they have not been proven for cardiovascular benefit. Now, icosapent, we can reduce it, has been largely positive with a reduction of 20%. And there is a new compound, volanorzeron, which has been shown to reduce massively triglyceride and some impact on patient morbid mortality. So thus, the 2019 recommendation for hypertriglyceridemia, has been revised. And the level of recommendation is the same, class 1, class 2A, level B, which is should be considered. But now the wording is high dose icosapent without the DHA or others due to the famous STRENGTH study. And as just mentioned, subcutaneously once a week, volanorzeron should be considered the same level of recommendation in patients with severe triglyceridemia due to familial, this is quite rare, familial chylomicronemia syndromes. For now, it is reserved to this population because the study was in these populations. Now there are new drugs. I will go quickly to this. It was presented at Madrid. Fantastic ApoA, small interfering RNA blocking ApoC3. and that's reducing pancreatitis. You can see that it is approved sometimes in the European market and not in the US. It's the opposite for some others. But there is no doubt, this is again from Borge Nordegard, Copenhagen, there is no doubt that there will be a lot of new agents coming, hopefully safe. What we know is that this is reducing by 80%. One of the failure of the anti-triglyceride was that they were reducing only 20% statin ezetimibe. Now we finally will have drug by antisense, and mostly, in my mind, that's personal small interfering RNA, very safe, should be cheap, but this will reduce triglyceride by 80-90%, and then hopefully we'll have a dramatic impact not only on cardiovascular disease, but on pancreatitis, but also on so-called NASH or fatty liver or non-alcoholic. They change the name quite often. I will go in, I think there is only two next categories of patients. These are persons. The persons who live with HIV in primary prevention, 40 years old or older, should now benefit. And this is class 1 of statin therapy. It's mainly due to reducing LDL in the blood, of course, and to reduce atherosclerosis driven by LDL. Why LDL is high? Because it's a chronic inflammatory disease. Even though they may not have too much particles, they will live very long due to the anti-HIV drugs. But these anti-HIV drugs, as you may know, also increase LDL. So clear recommendation now for statin in patient 40 years old living, or person living with HIV. And another group now is patients that benefit, I would say this, from cancer therapy, mostly chemotherapy. There is a new class of very high chemotherapy-related cardiovascular toxicity. There is an acronym for this. It's mainly due to anthracycline, actually, which treat lymphoma or breast cancer. So lots of patients that will benefit and live longer and hopefully with the same survival rate. But they might have some side effect of this anthracycline on the heart, on the left ventricular function. Nobody knows in my mind exactly why, but this could induce cardiac dysfunction. This is why there are recommendations to do echoes before, during, and after. But for the patient that are at risk of developing this statin therapy, and I don't think we know exactly how it works. It was some statin, pitavastatin, but I think it could be statin. It should be a statin that goes with others, anthracycline and other drugs. But statin now should be recommended in patients at high risk of developing chemotherapy-related cardiovascular toxicity. And I will finish, honestly, with the last, which is not the least as in importance, is we have no change in dietary suggestion for food. More cereal, more vegetables, all to be preferred, all these things. But what's changed? Due to one of these studies, this is one of the studies, the sports trial. Here, rapidly, you compare a statin, rosuvastatin, decreasing 38% LDL. Compare, and this is a placebo control, they're completely unblinded, compare to other vitamins or supplement, as mentioned here, garlic, BPRA, all these, none of them reduce LDL sufficiently. And this is why we place now to Benn. Class 3 are not recommended. Dietary supplements or vitamins without documented safety and, very importantly, documented safety and significant. We can discuss what means significant, but significant LDL lowering are not recommended. There is a huge market. And I have many patients who goes to groceries. It's out of recommendation now. It's out of reimbursement, of course. They use, and they could arm themselves. And this is why we place this there, that there are some of them, but very few that are safe and reduce significantly LDL. And this one would still be there, but for all the others, this is now banned. So in key messages, this focus with the help of fantastic collaborators, emphasized earlier earlier, more personalized and aggressive, it's not nice, but a more lipid-lowering therapy. Integrating SCORE2, SCORE2-OP, recognizing Lp(a) and lifetime LDL exposure, and expanding some options. I put here bempedoic acid for LDL. There will be others, and also introduce a new prevention strategy for people living with HIV and persons that benefit from cardio-oncology treatment. And I have to put this for ESC. You can download this, take this QR code. But for now, I'll be delighted to answer questions. Thank you.
Yeah, thank you, Professor Mach, for this detailed and comprehensive overview. May I start with the question? From my point of view, a really progress of this guideline is with regard to risk characterization and with regard to plaque and imaging of atherosclerosis. As you mentioned, you and your colleague switched the recommendation from two-vessel Connor disease with a cut point of stenosis greater than 50%. And I like this more pragmatic approach now, but I can imagine that this caused some debate in the background. Could you just shortly comment on that new, in my point of view, from my point of view, pragmatic, really easy and pragmatic approach?
Yeah, thank you. There was a lot of debate. This part was more from the Victoria Delgado, you know her from Spain, and using all the registries that we have now, using mostly CT scans and calcium score, that better qualify the plaques. As you know, we can even go now to look at fat, the pericoronary fat. They are indexed now using the pericoronary, the perivessel fats, and it was not the time to place this there, but I think this will better qualify patients than just 50%. If you have a 50% fixed calcified plaque, you are much less at risk than somebody who has even a low 30% narrowing, but completely unstable and non-calcified, soft, with lots of inflammation. And so hopefully this made, you're right, some debates, but at the end, honestly, as you know, we have to vote for all these recommendations that we proposed. This was, as the others, above 80% of everybody. And why not 100%? Some honestly vote by abstention because they were not completely aware, and we have to take this in account. But all the task force members, including the US, was completely in favor of changing this wording from 2019. It's 6 years. There have been a lot of improvement in imaging techniques, and I think it was a good time to better qualify this patient by these techniques. With the help of radiologists, sometimes it's not easy to have the help of radiologists depending where you work, but they have the machine so far. So, but it was not difficult debate. It was somehow an easy way to, I would say, upgrade, even though it's not. There are some new wordings. For me, it's an upgrade in the help or the better advice for our colleagues and ourselves to better qualify patients on imaging.
Also, from my side, François, thank you for this. I mean, one can still feel the fire in you, although you talk about this topic all the time, as you just mentioned, but you cannot be stopped, and you show so many interesting details. We're very, very glad, really, that you join us today. One question from my side goes into the same direction as Florian mentioned, the characterization and disease awareness, estimation of risk. There's one very tiny paragraph in the paper talking about lifetime risk and the way that you discussed amongst each other the way that atherosclerosis begins at birth, basically, and increases over lifetime. And we know the work of Brian Ference, but obviously we don't have prognostic or don't have randomized data on that. So there's no true recommendation, which I find somewhat a pity that we can't really tell people, check your LDL cholesterol even earlier, try and start treatment as early as possible, because basically we are often too late when there's already plaque and atherosclerosis has developed. Can you share your thoughts on that?
Yes, it as you mentioned, it's a great point. It's in the text. But to have recommendation, as well as me and others, you need to stick to data. It could be 1A, B, or C, it could be 2A, but you have to be based, there are rules. Class 1 is multiple randomized trials or meta-analysis, and then you have class A, B, or C. So we don't have data on lifetime risk so far. In the work of Brian Ference, mathematics, it's pure calculation. We will have them, and I will be so happy to include Lp(a) in score, because we're missing Lp(a) in score, even though it's, let's say, 10-15% of the population. That's a lot. So it should not be too much difficult to add Lp(a). It's easy, cheap to measure to the score, and then the score is more. I mean, it's 10 years only, but hopefully we will have score that will include lifelong, but that will take sometimes, I'm repeat myself, but to have this, hopefully in a couple of years, we will have the finalization of Brian Ference and others' work to be placed on a recommendation with might, should, or are recommended. Because you're completely right, it's a life, why we should measure LDL in every adult, so from 40 years old. Now, it should be a clear recommendation in order to be reimbursed. In some countries, it's still a cost. If you have to measure LDL and probably diabetes and blood pressure at 40 years old in a billion of Indians, that's going to cost. So as soon, it's going to take some time to have the lifelong risk of measuring all this. It seems so clear for us that we should do it, but we live in another world sometimes, in some of the bubbles, and we can be happy that in my office here, somebody come at 40 years old, it's going to be reimbursed to have LDL, Lp(a), without doing score to, if you want to check up at 40 years old, we do mammography, we do colonoscopy, we do all these things. But yes, hopefully we will see in a couple of years a lifetime risk. To probably to also have better patients adherence, because if you just mention to them that your risk of an MI or stroke in 10 years is 5%, it means nothing for them. If they see the Brian Ference curve, that your risk of having an event, including a death, from now 45 years old to 80 years old, which it's the next 30 years old, 35, it's 40%. That's a lot. So you just put something up, it's 50. Whoa. So that will help us a lot, probably, to check earlier and to have a better definition of patient at risk earlier in life, and to have even a better adherence, because they will see something that may happen in their lifelong. Everybody would like to live longer in a good, safety, healthy position. I mean, if my risk of a car crash accident is 50%, I'm not taking my car, period. So I cannot stop my life, but I will really reduce and put a second seat belt. And if you tell me with this way of driving, half a risk of an accident, wow, it will come.
If we switch now even to younger people, so not 40 years of age, but say 25 years of age, and surely you see these people, and in the absence of evidence from large trials, what would you recommend us to do in people with primary prevention, no risk factor, no smoking, so people who are exercising, who have a, say, LDL cholesterol of 160, 170. So my personal opinion would be to start them on a drug If they are somewhere between 130 and 160, I discuss it with them. If they are below 130, I say if there's no other risk factor, we do not need medical lipid lowering. Would that be appropriate in your view?
Yes, you're completely right in following guidelines. In what we do here, but that's a rich country. You also have rich countries around or rich population, and I do a lot of imaging. Because I see, and we all see patients that a person 70 years old, high cholesterol, no plaques. So in primary prevention, I will not treat numbers, but in plaques. But that's because I can offer echography of the carotids and a CT scan injected of my arteries, coronary. If the patient at 35 or 40 years old has no plaques in the carotid, neither in the coronary artery, without any lipid-lowering drug taken so far, I honestly don't see a reason to treat him. I will see him in the next 5-10 years. I will ask him to have the same habits, or if he should quit smoking, of course. It's probably cost saving depending on the price of CT scan, echo, and drugs. But it's probably cost saving for two reasons. First, you don't treat lots of people who doesn't need treatment. You may have some side effects. It costs. A pill a day costs. Even if it's cheap, statins, it costs. Secondly, for the one who you discover a plaque in the carotids and in the coronary, they will take their drugs. So you will treat the good one. You will not treat the one who doesn't need treatment at a cost, which is an echo there and a CT scan injected of the coronary. And that's not affordable in many places. I agree, sir. But in my mind, this is what we do. In primary prevention, the guidelines say you have to treat numbers. Honestly, I will prefer, for the two reasons I mentioned, but that's not in guidelines, to have, if I can offer imaging, and then I know they will, if somebody see a plaque on the carotid, a stroke is a big fear. Nobody laugh with stroke. And they take their drugs to reduce the risk of a stroke, mainly, or whatever MI. And the question is at what time you start these strategies of imaging. Honestly, carotid plaques, you can start at 20 years old because it's just echoes. It costs a little bit. For CT scan, it costs much more. So depending on how much costs a CT scan and irradiation that decrease nowadays, you can offer this from 40 or 45 years old. It's not answering completely your question. So you're not doing wrong. It's just recommendation. Again, if you treat numbers by somebody coming with familial dyslipidemia, 115 milligram deciliter at 40 years old, statins to everybody. Again, statins are very cheap. So it's one option, but you will treat a lot for nothing.
You mentioned Lp(a), and this is a growing issue, I think, because why I say an issue, because in Germany, people start to measure that. And if you are in primary prevention, and even from my experience, if you measure, you often have people in the age of 45 or so, and they come with 250 nanomole of Lp(a). And you showed this really informative pictures. I think it's not included in the guideline, and the concept of the higher the Lp(a), please get the LDL down. Could you comment on that? Because a lot of our viewers see this kind of growing issue with Lp(a), and the question what to do about that.
Yeah, thank you, Florian. We had a great debate about Lp(a). It was somehow difficult. There were latest data on epidemiologic from the US, and that clearly there is a correlation, and we put 50 milligram deciliter. Now, there are absolutely no good data showing that if I reduce LDL, it makes sense, but there are no data so far that if I have a high LDL, high Lp(a), by reducing LDL, which I know how to do, combination, blah, blah, that I will decrease the risk due to Lp(a) that I cannot treat. It is pure mathematics, and again, it's Brian Ference and others that it's not based on outcome studies. So this is why it cannot be on recommendation, but only on texts. But I take this example to students or to my colleagues here. You drive a car, everybody knows how a car drives. You have 4 wheels. Now suddenly one of the wheels is going to flat. So you decrease your speed until you come to the first garage to change this wheel. Now, decreasing the speed is reducing LDL as much as, and by 1, 2, 3 years, then there will be a specific drug for this person to change their tire and to reduce completely Lp(a). But it has not been proven so far that by reducing LDL or my speed, I'll have less risk of MI or car crash accident until the garage or the injection of whatever drugs to reduce Lp(a). So that's why it's, honestly today, we don't even know if reducing Lp(a), we cannot tell that Lp(a) is causal. LDL is causal because we have the genetics, we have low LDL due to genetics, reducing blah, blah. So Lp(a), we don't have very low Lp(a) by genetics. It's only increased. And we still don't have the data that reducing Lp(a) reduce events. So the first step probably will be in recommendation, to place recommendation that we should use these drugs to reduce events. Until these data are there, it's not recommend. We cannot place in recommendation to lower LDL, even though it makes sense for you, for me, for lots of patients. If you take time to explain to them that they should reduce their speed even lower because one flat is not good. It's not their fault again until we can fix it. But honestly, they are not so far, in my knowledge, in our knowledge, good data about lowering even lower LDL than recommendation, which is something bizarre, if you have high Lp(a).
Well, François, thank you so much for these insights. I mean, I think we could have talked or could talk forever. There's so many open issues, as you alluded to, for which we're still lacking data. We'd love to discuss on angioprotein-like 3, on the CETP inhibitors. There's so many things coming up, and will most likely be part of the new guidelines that we can expect in some years from now. Maybe
There will be. We are discussing with the ESC. We can finish like this to stay tuned. There will be probably a full update, depending on some Lp(a) and oral drugs by 29. I think we can be optimistic, but that means that the group should start tomorrow. But it will be probably for 29. Before, I doubt that we will have enough, but 28, but 29, I'm optimistic.
And we know how much work it takes to bring these guidelines together, and we're so thankful and grateful that
thank you.
that you're busy with that, and maybe we'll get the opportunity to talk to you again in the future about these things. So thank you very much indeed for your insights and your great presentations and your answers to our questions. Thank you.
Thank you for the invitation. Thank you. Pleasure.
Thanks so much. And we have to stay online then, Stephan, Florian, until 2029, huh? Yeah. Thanks so much.